Dear colleagues, welcome to this sponsor session sponsored by Obsense Medical. My name is Thomas Cuisset. I'm working in France, as you can hear with my English accent. Now, more seriously, as you will see, this session is very an innovative one because we've seen all over the meeting a lot of sessions, let's say, on the common topic. But on this one, you will see combination of two innovative strategies. One based on physiology and one based on the use of drug-coated balloon, which is, as you've seen during the overall meeting, one of the big trends in the coronary intervention. So here are my conflict of interest. So just during this very short introduction, because the idea is really to go straight to the session, the idea and what we would like to achieve together during these 45 minutes, it's to see first the new potential application of coronary physiology to safely limit stenting in complex PCI, including CTOs, to debate with cases on the impact of the technology on the interventional strategy, and then again to explore potential development of new modern technique in complex PCI, with new tool to assess and new tool to treat. So to do that, I have the privilege to have a great team, and as you will see, we will have mainly a session which will be case-based. But before that, it's my honor to invite Professor Colombo to give us just the clinical rationale underlying the use of those technology in the cases that you will see just after. Professor.
Thank you very much for these opportunities. I will try to be concise. I have a 5 minutes presentation. Rationale to use a drug-coated balloon. I have no conflict to report. I wrote this point of view with Dr. Pier Pasquale Leone last year, redefining the way to perform PCI. Nothing against stenting, is just to highlight the fact that the stenting may not always, I say always, be the default approach in coronary interventions. And I start with a most extreme example, but again, I don't want to go against stenting, but I want to go against stenting in situations where it may not be appropriate. This is an 80-year-old gentleman with a long LAD lesion and a long RCA disease. This gentleman is in atrial fibrillation. He's taking oral anticoagulation, NOAC. And if in this patient we may limit stent length, may be appropriate. So I believe this is a classic example where the usage of stenting should be limited, maybe not totally forbidden, but limited. To place a 240 millimeter long stent on the LAD and a 3 long stent in the right coronary artery, I do not believe is the best approach for this gentleman. This was, we were lucky. We did pre-dilatation with no dissection or minimal dissection, and we used a drug-coated balloon. I think this is an acceptable strategy to avoid stenting in a patient who long stent may not be a well done service. This is a 6 months follow-up with good result. This is another example where I think stenting may be not ideal. It's a diffuse disease circumflex where stenting at the ostium may cause carina shift and may sometimes a need of additional intervention to the LAD. We pre-dilated with a reasonable result, not optimal, but again, we accepted and did a drug-coated balloon with a good 1 year result. So again, these two cases are not meant to go against stenting, but to use other technologies when stenting is not ideal. And I would like to finish with the value of physiology. We like to use physiology, especially when we have to treat a long diffuse disease. This long diffuse disease of the left anterior descending may not be ideal even for surgery. I'm sure that a skilled surgeon will be able to deal with that. We used a short drug-eluting stent proximally, 3.5, and 2 long DCB. Being diffuse disease and difficult to evaluate, we perform physiology and measure the pressure gradient with the pressure wire to support that there was no flow-limiting dissection. I think this strategy has been utilized quite extensively by our group in the left anterior descending, and if you have time to read this retrospective study by Mauro Gitto with 147 patients treated with this strategy, utilizing liberally pressure gradient to evaluate the result, I think will be useful. Again, this strategy is ideal for the left anterior descending. There is some trend of an advantage when you do a propensity matched with a strategy utilizing long stent. This is a final slide. When you see this diffusely disease LAD with an FFR of 72, is not easy to select where to place a stent, maybe a long stent from here to here, but there is additional disease distally. In this situation, we use a pressure wire guided strategy. We did pre-dilatation with a balloon. We left the pressure wire distally, and the FFR is 87. The PDPA is 94. I believe this allowed us not to stent and to use just drug-coated balloon. There is a paper by Pier Pasquale Leone in JACC intervention with a series over 100 patients. These several DCB with a final result. Thank you for your attention.
Thank you, Professor Colombo. Just to remind you that we have mics in the room to get questions, but also, of course, we have the online system, which probably makes sense in the main arena, but here feel free to stand up and to ask questions. Interestingly, we have a question from Salma, asking if you think that in this kind of LAD, intracoronary imaging should be mandatory, let's say, to assess the degree of dissection and whether you can safely defer stenting.
I think intracoronary imaging is useful. It's more difficult to interpret than a number. A number is easy, but intravascular imaging is very important if you know how to read it. And the main goal is to have a true lumen which is large enough, even if you have a dissection nearby, but the true lumen is sufficiently large, the dissection will not be able to occlude the vessel because the flow in the true lumen will take the prevalence over the dissection.
And do you take the same criteria that we use for optimization, meaning the 60-degree dissection to decide whether you can stop it?
Yes, exactly.
Yes, please.
Antonio, congratulations for the presentation. I completely agree with the strategy and the messaging in advance that we don't move out of our cath lab the stent, but it's another hypothesis. I completely agree. I want to ask to you the suggestion and what is your idea regarding the more confident to leave the result. Normally, if you perform a DCB, you use angiographic evaluation. Our eyes to see that less than 20% and dissection. And to move more safe, but also in terms of efficacy in the long term, the use of functional evaluation. Which is your idea regarding the angio-based system? I do a lot, but you believe that we need with the wire-based, or is possible to use also the angio-based? Your feel,
I do not have sufficient experience with QCA, with angio-based system, but I know there are many systems now coming, and if they are well validated, why not? But I want to be convinced that these systems are validated.
Yes, please.
Yeah, thank you. I have two basic questions. One is, which drug-eluting balloon you prefer, paclitaxel or sirolimus? Number one. And number two, if you use a short stent and then use a DCB, with a different drug composition in stent and balloon, is there any problem of using, say, everolimus and paclitaxel, everolimus and sirolimus? Is there any problem?
The first question, I'm using three main DCB in my practice: the B Brown, Sequence Please, the Solution, and the Concept Medical. I've been doing this for the past 3 years, and next year we will have the follow-up, and I will answer your question. Ultimately, I want to use one, maximum two, but maybe all the three are effective. But at the present time, I think the jury is still out, and we do not have sufficient data to say which is the best. The second question is about the overlap of a stent with the drug and the cut in the DCB with a different drug. We did not see any concern. We have published a paper 5 years ago addressing the combination, utilizing a drug-coated balloon plus a drug-eluting stent in patients on dialysis, in patients with creatinine over 3, which are prone to restenosis, and we did not find any safety issue. There is not a specific study, so this is just a series. But so far, we didn't see any safety issue.
So I have a question. We were doing a case, it's sort of a one-off thing, but I'd like your comment about it. It was a mid-LED, and the FFR was below 0.8. We went ahead, prepared the lesion, did the DCB. And the post-FFR was also below 0.8. So you're thinking about, although angiographically it didn't look bad, and we had TIMI-3 flow, we were thinking about maybe putting in a stent. We post-dilated it after we dilated the lesion with a non-compliant balloon after having done the DCB, and just check the FFR before putting in a stent, and it turned out to be better. And we just left it there. We'll probably follow him up for an angiogram after 6 months. I don't know. Would like your comments about such a strategy, and would somehow doing a balloon after doing DCB somehow affect the drug that may have been eluted or not eluted as yet completely?
But I think in this situation, we found useful to do intravascular imaging, because you may spot a short area where you place a short stent, and that may really dramatically change your FFR. So we published many years ago the paper about spot stenting, and I think there is still a value of placing a short stent, even if there is areas which have not been stented, provided the residual lumen is good, of course. You don't want to leave a significant stenosis proximal or distal to a stent. But if you prove that the residual lumen is large enough, it's okay. You don't need to cover the lesion entirely with a stent.
Maybe Professor Colombo, last short question and short answer, if possible, from Daniel about the duration of DAPT after DCB in your practice.
We always give at least 1 month of dual, not single, especially if there is some residual dissection, because I think dual antiplatelet therapy is protective if you have a lumen damage. So 1 month of dual, we give it.
Okay, thanks again. So We already start a nice technical discussion, so now it's time to move to the case and really to see how we can apply those strategies. And it's my pleasure to welcome Med Ayoub from Germany to present, as you will see, a first challenging case.
Yeah, thank you so much for introduction. Thanks for this very interesting session, in my opinion, because it's going to be our future, how to treat lesions. It's not just about dilatation, putting a stent. It's going to be more a hybrid approach, maybe, with DCP, pressure wire, imaging. We need all these tools to decide how can we do the best for the patient. Okay, so here are my disclosures. So what we are going to see in my presentation, pressure wire assisted treatment, and how may we use DCP, especially in EuroPCR, and how can we do a good plaque modification in severe calcified lesions. So it's about a 74-year-old male, 3-vessel disease, preserved at ejection fraction. We have a previous angio with a negative IFR of the LED and intervention of the circ, and it was remaining CTO of the RCA with GCTO score 2. I will show you the previous angio. So you see, appreciate the severe calcified long lesion of the RCA. There is an occlusion in the middle RCA, not that long, but severe calcified. And you see collaterals coming from retrograde. It's a big RCA. And what we see, a lesion in the circ. And in the cranial view, you can see the lesion in the middle LED. Where they have done an IFR, it was negative, so they didn't treat that lesion, of course, and they just put a stent into the circ, and with a good result. So, of course, the patient came back because it's a huge vessel, the RCA, so for the recanalization, and so we did that procedure. My question is, you've seen the first shots, so we should discuss here. It's going to be a more interactive session. So, who would go for let me say, retrograde first? One? It's very interesting. Or two, maybe?
Two, maybe.
Okay, so who would go for antigrade? Who would don't do EuroPCI at all?
Yeah, that was my next question.
Okay, so we have some. Okay, interesting. So just one answer from who would go directly for retrograde. Why? So because, thank you.
It was long CTO, heavy calcified, and I didn't see the proximal cap, and it was probably a favorable collaterals from the left. So.
Okay, sure. No, I mean, there are reasons how you would go directly for retrograde. So I think, in my opinion, it's always worth to try antigradely. You don't need to try maybe 1 hour or 2 hours, but just to try maybe for 10 minutes. And if you are lucky, you can solve it antigradely. So it's just in my opinion. So as the majority here, we have done antigradely. So, as you see here, I tried first with the Filda XTR, and it's a Corsair microcatheter because we have calcification. And after that, I had to change to the Gaia Next Second. The Gaia Next Second is, we have it recently in Europe, and it's very good wire because the tip of that wire, it's very strong, so you don't get troubles to get stuck with the tip in calcification. And as you see, it went really very easily to the distal part, so it took just 5 minutes to be distally with the wire after changing and escalation from Filda XTR to the Gaia Next Second. And you see, I do the contralateral injection because I want to be sure I'm in the true lumen, not only trust my tactile feedback, which is also important, but also to inject retrogradely and to be sure I am in the true lumen. You see here, I try to enter to the PL branch also, to just for more being sure I'm in the true lumen. After that, I can cross with my microcatheter, which is a Corsair. It's a talkable microcatheter, and it changed to regular wire. Just I had difficulties to cross with a microcatheter, so I had a lot of friction. I was able to cross, but I had a lot of friction and it was a little bit tough. So my question is for you. What would you do?
Mohamed, I think we can move a little bit forward in the case,
Yes.
and maybe we will stop a bit later during the case.
No problem. So what I have done because of that difficulties, so I did a rotablation atherectomy because, as I mentioned, it was not so easy to cross with a microcatheter. And I did a rotablation 1.5. As you see here, multiple runs. This is the distal part because all the way down was calcified. So, and after that, I will just go ahead. You can tell me if we need to stop, please. And after rotablation atherectomy is the question, what next? Should we go for balloon dilatation? Should we go for pressure wire measurement or imaging? And what you see here, I want to understand what's going on in the vessel. So for that, the best option would be to do imaging. You see here the IVOS coming from the distal RCA, like calcium ring, and at multiple places. Here also calcification, and in the middle RCA we appreciate eccentric calcification here also, so we should be careful while balloon dilatation in eccentric calcification. And also up to the proximal part we have again calcium ring, so we should do something in that vessel, not just go for easy balloon dilatation and stenting in best way. So after this imaging, just one question: who would do more plaque modification, and who would say, okay, I try with balloon dilatation and stenting? Who would go for stenting? Nobody. Okay, so this is actually the message, and this was my idea actually, also to do a proper plaque modification. I had only 7 French guide from Cordis, so it's not possible to take the 2.0 bore, unfortunately. So for that reason, I decided for the 175 bore. This is what I have done. I rotablated all the way down with the 175 bore. And after that, again, the question, what to do next? More plaque modification, or are we successful? I don't know that. So again, I need imaging, which shows me, am I successful? Am I happy with my result before stenting or DCP, or I need to do more? So here again, IVOS, you see, we still have calcium calcification and calcium ring at multiple places. So it didn't help that much, and you appreciate again the eccentric calcification in the middle part of the RCA. So I would go forward. You see here, is a rotablation atherectomy enough or not? We know it's not enough. So what is next to do? Who would go for IVL? This would be my question. Who would go for IVL? Okay, so it's nice. And who would go for NC balloon dilatation? Also okay. It might work, I agree. But I had also eccentric calcification in the middle part of the RCA. So we can consider maybe it's safer to go with the IVL. I don't know. So my choice was to go with the IVL first. It's 4.0 balloon. I put all so the balloon at multiple places. You see in the middle part, I gave like multiple runs because there I had the eccentric calcification and calcium ring also. And after that, of course, we need the NC balloon dilatation. So my choice was here to take the open-end balloon. It's a 4.0 balloon, and I was able to crack the lesions up to 35. Usually we try to take the open-end balloon a little bit smaller than NC balloon to not perforate, of course. So here it's 4.5 vessel. I take 4.0, and I am safe somehow. So
Mohamed,
what
do you agree
next?
that usually it's probably safe to try non-compliant balloon first, and maybe OPN if it doesn't work as a no?
Of course.
Yeah.
Of course. I mean, I had the impression it's really heavy calcified, calcium rings at multiple places. We can, of course, but it would be also possible. Yeah. I agree. So what to do next? After that, again, imaging, because we want to see what did we achieve with our treatment. So you see here, we will see multiple fractures of the calcium. We saw that in the distal part, and here also at 9 o'clock you see one fracture, and now at 1 o'clock, and here also. So we achieved at many, here also It's too much fracture for my opinion. And here you see again at 9 o'clock one fracture in the calcium. So we achieved a lot with our plaque modification, and now we can decide how to go forward, DCP or stent, because it's a long lesion. So it's always easy to put everywhere stents. But is it good for the patient? We don't know that. We don't think so. So our aim for the future to reduce the number of stents, if possible, of course. And to know how to do that, we need to learn about this. And so drug-eluting stents, or drug-eluting balloon or stents, I did the pressure wire measurement. From distally, you see we have, of course, pathologic value distally. And we have the jump of the value in the middle part of the RCA, where we had the recoil inside the lesion. So for me, if I see that, I would go for stenting that part where I had the jump of the value and leave the rest of the vessel maybe only with DCP. We will see how it works. So I put stents in the middle part of the RCA and just left the distal part treated by DCP, so I could save like at least 40 millimeter stent length, which is good for the patient. What we can see, there is a proximal dissection in the RCA after the ostium. I had the question, should I go for stenting or not? Who would go for stenting that dissection? But we heard from the last presentation from Professor Colombo, he is not here anymore. If you have a large vessel, so you may leave the dissection also. So we still don't know. I don't know, maybe treated by the NC or catheter, whatever, we have a dissection in a large vessel. So the question is it okay to leave it with DCP or going for stent?
The point is probably induced by the guiding, they say, the proximal dissection. That was the point.
Maybe.
Yeah. With the armplats, which probably...
Maybe. So, So, of course, for safety reason, I went for stenting that vessel, also the proximal part. So to be sure we covered everything. So this would be how we do. I will just show you the final IVUS after all this treatment. This is the distal part where we just put DCP, so no huge dissection, so I'm happy with that. And here we see the stent in the proximal part, well opposed, and no release relevant malapposition. So we end the procedure with 2 stents and 2 DCP. In summary, IVUS and pressure wire assisted treatment, especially in complex procedures and CTO-PCI, may help us evaluate the plaque modification and reduce the number of stents. And the hybrid approach of using DCP and a drug-eluting stent is important for CTO-PCI because we have long lesions. And, but we need, of course, randomized trials showing us how important is that and how useful is that for the patient. So we are trying to build up a randomized trial to answer that question. And proper plaque modification, as always, especially in severe calcified lesions, may require multiple tools, as you see in this case. Thank you so much.
Thank you, Mohamed, for this beautiful and challenging case. Yes, we have time just for one question because we have to move already to the next case. Yes, please, we have mics just there. Please.
It's so congratulations for this procedure, but it's too expensive, I think. Yes, why not two drug-eluting stents, and then with short depth, with new generation? Why not? Why drug-eluting balloon and you have 2 stents in?
So we think then less stents you have and less stent lengths, then less TLR and MACE rate after the procedures you have. Of course, it's a big difference if I have 60 millimeter stent length or 120. The immediate result, it's always nice after stenting, but I'm talking about the long-term results. Is it better for the patient to put more metal inside the vessel? I don't think so, but we need the answer from randomized trials. I totally agree.
Yeah, that's the problem today with DCB, that we most of us, we do that. We hear that a lot in the meeting, but we still need the evidence to support what we are doing. So thank you again, Mohamed.
Thank you.
So now we move to the next case, which, as you will see, will be as challenging as this one. And we'll ask Ludovic Baldowski from Slovakia to present this case. Please.
So hello, thank you for the opportunity to speak here. We have heard a lot about the long calcified lesion and something about the role of DCB and how to stand DCB in the CTO lesions. But for me, there is just the third clinical scenario, and it's the patient with multiple vessel disease, and it doesn't have to be like really challenging stenosis, but there are a lot of stenosis, and you just need to treat them. So I will start right with the case, and then we'll go for something else. So it's the 75-year-old patient with hypertension, hyperlipidemia, obesitas, and he's after recent stenting of the LAD, which has been in the middle and distal part in August. In December, he just got chest pain during physical activity, and it has been progressive. So in January, he came back in the cath lab just to look if everything in LAD is okay. And we find out that there is the LAD looks good in the distal part, but we got intermedial branch, obtuse marginal branch, and right coronary and PDA. We got it whole with the stenosis. We did the physiology. Every stenosis came as significant. So what to do? Here are the places where we measure them, and the chart for them. What to do next? Actually, even if there will be still the stenosis in the LAD in the mid and distal part, I don't think that it's a patient for the surgeon. It's patient for interventional cardiologist. So we have actually just 3 scenarios, because patient is symptomatic, we need to treat them. So we just need to realize if we will go like first for DCB strategy or DES strategy or some scaffold strategy. So who will go for DCB strategy as the main strategy? Okay. And who will go for DES strategy? And who will go for surgery? Okay. Okay, so just one.
Are you cardiac surgeon? No, I'm joking. I'm joking.
So we go for the DCB, and what we see a lot of back in our cath lab last 2 years, we are using a lot of DCB balloons, and we see that even after not the great angiographic result, right after the PCI, after that the angiographic result is good. So we did some predilatation. What I think that is the clue of the main DCB strategy is that you have to think about DCB like you need to do really aggressive dilatation. You have to crack the calcium, you have to avoid the recoil in this part. So in the intermediate branch, we use scoring balloon, NSA alpha, and after that, a high pressure NC balloon. In the obtuse marginal branch, we use high pressure NC balloon, and also there was used scoring balloon in the PDA and high pressure NC balloon in the right coronary. You can see that the result of the measurement has been like around 0.90, 92 in the distal part of the vessels. So what we are doing now is sometimes we call them back for the measurements, because we are counting on the positive remodeling of the vessel. This is the same patient after 1 month with the paclitaxel eluting deep DCB. And the DPR and physiology, all the vessels are open. The short cutting lesion in a PDA is completely healed. There is still some dissection in the intermediate branch, but the physiology there has risen. Also, it's really normal physiology in the first obtuse Magellan branch, and we could say it's normal physiology in distal PDA. So, what we are actually, it's all about our comfort in the cath lab, what we can leave and what we cannot leave when we are doing with DCB. So we are doing some, from the beginning of the year, we are doing some observation just for us, where is that cutting limit. We are doing PCI with DCB, you do aggressive dilatation just to reach your goal. And you discharge patient on DAPT, readmits after 1 or 3 months. And just exclusion is if you are unable to reach DPR or the residual stenosis is more than 50%. We just have 1 patient when we have been unable to reach DPR goal with balloons, and it has been same with the stent when we implant the stent. So as we believe that there will be some positive remodulation, first because of the dilatation, second because of the drug-eluting balloon, we set a lower cut of DPR for 0.8 for CTO or subtotal occlusion and DPR 0.85 for stenosis. Till today, we have just measured 23 lesions, but in every case, we see improvement in physiology. Mean DPR improvement is 0.065, and we just have 1 patient where the improvement has been not so great. It's from 0.85 till 0.88 and 89. So he has been on the table, so we stent it. What is the conclusion for me? How to use the DCB in our daily clinical practice is that you just have to be comforted that there is no need for instant optimal angiographic result. You just need to have good flow, because if you proper dilatate, you could count on positive remodeling of the vessel. And there are two main reasons which is using DCB in a patient with DES for me, which I want to highlight, and it's that you are using DIPT in DCB just to heal the wounds, because you are nothing leaving behind. So you could be really comfy if you didn't do really bad wounds in the vessel. You could be really confident after 1 month. Yeah, it's like really safe to leave it, because you don't need to have DAPT, because there is nothing in the vessel more. And in multivessel disease patients, I'm pretty sure that everybody here in this room will do this easy case like excellent. The result will be instant excellent. The patient will be like free of symptoms. But the difference is at the end of the day that you could have asymptomatic patient with multivessel disease and 6 stents, or asymptomatic patient with multivessel disease and with no stent. So, thank you.
Thank you. It's a beautiful example of how the combined use of physiology and DCB can improve the management of such patient with diffuse disease, because so far we use physiology to treat or not, but now it's to use physiology to decide how to treat, sometimes between DCB and DES. So you open new perspective, and we'll see in the coming years how it will apply in clinical practice. Mohamed, you have a question?
Just one short question from my side. So it's very, as you mentioned, it's important to make a proper plaque modification before we go for DCP. But on the other side, we don't want to make big dissections. Yeah. So we still, to be honest, me too, I still don't know how to treat these vessels if my primary strategy would be the DCP. should I go for like aggressive plaque modification, as we do usually, a proper plaque modification before stenting, or just be a little bit more defensive, to not make conservative, to not make big dissections? So I think it's not easy always to answer this question. What would be your opinion?
For me, I don't think that we will use like DCB in 100% and then DES. No, but I don't think that it's good that we are using 98% of DES and 2% of DCBs. I think it could end up 50-50. Means that, okay, if you create some really big problem in the proximal part and you just use short stent, why not? Why not?
But in your opinion, our strategy regarding plaque modification should be like if you would go for stenting. It doesn't matter if I go for DCP or drug-eluting stent.
Yeah, you just need to go like aggressive, because usually when someone uses DCB, it's like, okay, I take their balloon, which is ratio 0.8:1, and okay, it looks good, so I'm going for DCB. But this is why the patient came back with recoil, because you need to do it like properly.
I think you have to prepare properly, otherwise there will be residual stenosis and more TVF. So it's yes, please.
Congratulations for your beautiful cases. I think it's very intriguing to combine the two technology or two modalities, physiology with drug-coated balloon usage. I think in the distal or smaller or secondary branches that you were alluding to, I think it's quite safe and quite good to use drug-coated balloons. But I would a little bit caution against using physiology post-intervention to prove that the result is fine. And I think the changes that you see with the post-PCI DPR compared to the later on physiology is that it's not really resting hemodynamics. I mean, you did a lot of ballooning, a lot of work there, cutting balloon, whatever, to prepare the lesion for drug-coated balloons, and then you do the drug-coated balloon with long inflations, of course. And you take the measurement, it's definitely not resting. So whatever you measure there is going to be somewhat hyperemic or quite hyperemic. And this is why I think there is no cutoff value that you can use and at the end of the procedure. I would like to have your comment on that, because we've been struggling with the post-PCI FFR cutoffs, and so many values have been proposed so far, and nothing really works. We know that the higher the better. And I think it applies to your case, drug-coated balloons as well. But is there any value that we can trust, that if we reach that, we are fine and no stents are needed?
I think that's a very good point.
I think that in most cases you don't need this physiology. This is just how to try to find something that could help us, or that could make you comfortable. That okay, if I leave it with this number, I have 99% chance that it will not close or it will stay open. But I don't think that you need like physiology for every case. And for sure, it's not the same physiology like in the beginning. So yeah, it's a long way still, but everyone will try to have.
Thanks a lot. Maybe just one word to conclude this session, and really to thank Obsense Medical who dare proposing this kind of session, because as you know, during the meeting you will find I love a lot left main and bifurcation, but you will have 50 sessions on left main and bifurcation, but you will just have one session like this to really try to open our mind about new strategies. It's true, as we say, that it's not based on strong evidence as of today. So it's just to discuss, to share our practice, and to see whether we can improve from what we are doing on a daily basis. So again, thanks a lot. And of course, thanks a lot to the speaker and all of you for attending this session. Thanks a lot.